Manushi, will wait for a couple of minutes for more people to join,
Yeah.
and then probably we'll start the introductions.
Sadak has joined. Can the participants hear us? Yes, no?
Manushi, I think we can start.
Yeah, let's start. Thank you to everybody who's joined this webinar. It gives me great pleasure to welcome you to episode number 3 of our webinar series on evidence-based primary healthcare. A little bit about the primary healthcare research consortium. We're a collective from which represents several countries in the global south. At present, our secretariat is based out of the George Institute of Global Health in India. We have 4 studies that are currently funded by the consortium, and in this particular study, we're going to discuss about the results from an international survey on integration of public health and primary care in COVID-19 vaccination campaigns. In this study, we collaborated with the Besor Center with Dr. David Ponka and his team, and we wanted to really understand how are countries rolling out their COVID-19 vaccination campaigns, how integrated is the public health and primary healthcare effort. I'll introduce you to the team here. I am Manushi. I'm the manager of the consortium secretariat. We have Dr. David Ponka over here. Dr. David is the director of the Besor Center for Global Family Medicine at the College of Family Physicians of Canada. He has also served as the research director and the chair of the Center's Advisory Council. He's a family doctor by training and also teaches family medicine. And he has extensive experience in caring for vulnerable, the migrant populations in Canada and abroad nations such as Haiti, Chad, Guyana, where he tries to support integrating research into the new discipline of family medicine. So thank you, Dr. Ponka, for making time for us. Would you like to say something right now? Or?
Hello, thank you very much. It's a pleasure to be here during Diwali week. It's nice to see so many familiar names joining. Hello, everyone. And I'll also make sure that my team has a chance to introduce themselves.
Okay. So moving on, we have Rifka Chamali, who is the Special Projects Manager at the College of Family Medicines of Canada. And also she has Rivka, remind me, what is your training in?
It's in neuroscience.
Oh wow, yeah. So she's a neuroscientist by training, and also is interested in primary healthcare. Then we have Dr. Sumit Sodhi, who's a physician is a clinician scientist at the University Health Network and the academic lead for the Indigenous Health Partners Program at the Department of Family and Community Medicine at the University of Toronto. She's a staff physician, and she has extensive work experience as a field doctor, program consultant, and researcher in global health and resource poor contexts in Africa, Asia, and Canadian northern communities. She and Dr. David Ponka are the co-leads for this study. And if you want to add a few words, Sumit or Rivka.
Thanks, Manushi. Yeah, looking forward to sharing our results. We've been actively working on this this past year, and thanks for giving us the opportunity to share.
That's great. Thank you so much. So before we jump right to our presentation, some housekeeping announcements. Please, for your questions, I encourage you to use the Q&A box. It's easier for us to track all your questions. And for any insight that you might gather from this webinar, I encourage you to post it on social media, on Twitter. And our social media handle is care_PHCRC. We're very active. And Rivka, if you'd like to give the Besor Center's Twitter handle, please type it in the chat box.
We don't have a Besor one, we just have a general CFPC handle, but I'll give that as well. Okay, great. So with that, and also we'll share the presentations with you and the recordings with you after post this webinar. Anything else? No, I think not. With that, over to the team to start with the presentation.
Thank you very much, Manushi. It's been a real pleasure collaborating with you, with the team at the George Institute, with the whole PHCPI structure, and of course with my valued colleagues Rivka and Sumit. It's been a lot of fun doing this project. I'll start sharing my screen to share a PowerPoint, and we're very excited to be sharing some results and progress on this important project around the role of primary care providers in integrating with public health to deliver more effective COVID-19 vaccination programs around the world. Can you hear me okay? So yes. The agenda is for me to set the context a little bit very quickly, for Rivka to talk about the background and the methods for the study. I'll be addressing some of the imperatives. She'll be addressing some of the background. We'll take a short pause after that, see if there are any burning questions or discussions, and then we'll launch into our emerging results and also get feedback from you as we write several papers from this study. We really want to thank the whole team. We could not have done this without you because of your extensive support. Thank you for the Primary Healthcare Research Consortium, Praveen, Manisha, of course, Felicity, Bob Mash, and Marcelo in Argentina. We are just about to publish the methods paper on this study in the African Journal of Primary Healthcare and Family Medicine, and we hope to continue to disseminate our results. The Besor Center is a hub of global collaboration. What a momentous time we are in. What a historic time we are in, and there's perhaps a tendency to become parochial during times of crisis. This is a human tendency, but we are very much in the mode of forging new and more global collaborations at this critical time to continue to share lessons. We have supported a fellowship in South America, a series of grants in Indonesia, and South Africa, including with the collaboration of Bob Mash's team. And we hope to continue in this trend and concentrate efforts in sub-Saharan Africa in the next years to come. You will see some slides on global equity. This continues to be a great concern around the world. And this is our primary value, that of reaching for equity and reaching for reciprocity. There are many lessons to be shared across contexts. When I was hired and continue to learn from Catherine Rouleau, who's on the call, you know, the impetus was very much to export family medicine values from Canada outwards. But just as often, we're bringing lessons back home. And we have a couple of slides to show that. That's low-income countries, middle-income countries do certain aspects, especially around integration, much better than we do perhaps in North America. So to situate the study, we've all seen this graph around the 4 waves of the pandemic. By 4 waves, we do not mean infectious waves. Tseng rather means the chronic waves of impacts on patients and communities. The impacts around delayed diagnoses, but also the impacts around psychic trauma, mental illness. And I think we are still all feeling that. And as we move further along the waves, we're realizing that we vacillate between priorities, between infectious priorities, chronic disease priorities, educational priorities for our children. And really, truly, we are seeing the importance of integrative thinking. And this is what this study is about. On a personal note, in Canada, we saw many instances where family physicians were perhaps underused in the COVID-19 vaccination campaigns. We are trying to correct our course, but there were many stories in the press and in the academic communities about how this was under the purview of our public health colleagues, who of course have a lot of experience and can mobilize quickly. But as we'll see through the study, the role of family medicine is that of a personal connection with our patients and perhaps seeking and outreaching towards harder to find communities and patients. So we were somewhat overlooked, and we are trying to correct our course. And our college, the Besserer Center for Global Family Medicine, is under the College of Family Physicians of Canada, has a position statement to this effect. This study very much builds on Felicity and et al. Study published in BJGP Open 2020 around the relationship between perceived strength of country's primary care system and COVID-19 mortality. And the team very much found the importance of integrating the public health and primary care sectors. Rivka will help us situate and remind us of the differences here in the terminology, but we very much seek a robust primary healthcare system by integrating primary care and public health. Felicity et al. Study was a survey, as is ours, and is based on perceived responses, perceived strengths, and we built on this and focused on the importance of integrated systems. As I mentioned, equity continues to be a great concern. As of Monday, we are still seeing a very unequitable distribution of COVID-19 vaccines. These are populations receiving even one vaccine. Only 23.3% of people in low-income countries as of Monday have received even one vaccine. This is a travesty. Canada has had certain policies that perhaps contributed to this inequity, including around what was seen as potentially keeping a lot of vaccines and seeking different contracts from around the world. And this study is in part to try and remedy that unfortunate fact. I will now pass it on to Rivka to tell us more about the background, primary healthcare, and our methods. Thank you.
David. So I'll start with a bit of background. And so health is a fundamental human right. So as David mentioned previously, there are many health inequalities between, but also within nations. In 1978, the Alma-Ata Declaration recognized that health is a fundamental human right, and that the key to achieving health for all is through primary health care. So the goal was to reduce health inequalities and to attain acceptable and equitably distributed level of health throughout the world. So sorry, David. So, and then in 2018, the Astana Declaration reiterates the importance of primary health care in achieving universal health coverage. So the ability of people having access to health services, irrespective of their ability to pay for it. Next slide, please. So what is primary health care? Primary healthcare is a whole of society approach to health that aims to ensure the highest possible level of health and well-being to individuals by ensuring that access to healthcare is equitable. So equity is something that is very central to this. And that means that all individuals have a fair opportunity to access health services. And that's regardless of income status, social status, gender, race, or geographic location. It has to be people and community centered, so it has to be based on people's needs and their preferences. It has to be comprehensive care along the continuum of life. So it will include things like health promotion, disease prevention, treatment, rehabilitation, and palliative care. And it has to be accessible to the people and to the community, so it has to be close to people's everyday environment. So the term primary care refers to the key process in the health system that supports first contact, accessible, continued, comprehensive, and coordinated patient-focused care. Next slide, please. So primary healthcare-oriented health systems are composed of structural and functional elements that maximize equity, provide access to services that are acceptable to the population, and support in achieving universal health coverage. And one of the key components of primary healthcare is to have an integrated health services where primary care and essential public health functions are the core of the health system. And next slide, please. So as I mentioned previously, primary care is the first point of contact in the healthcare system, and public health is the necessary collective actions that are fundamental to improving, promoting, and protecting the health of the population. So they both have overlapping functions and can achieve greater outcomes by their integration and coordination. And next slide, please. Yes. So now I'll do a little bit of an overview of primary care and public health integration and vaccination campaigns. So studies show that, primary care and public health integration and immunization programs led to successful delivery and wider national coverage. So the role of primary care providers in delivering successful vaccination programs is because they're a trusted source for vaccine information and they can help build local community trust. They are able to reach vulnerable and marginalized communities, so all of that contributes to good uptake. And public health, on the other hand, has a key role in establishing the effectiveness and safety of vaccines, responding to outbreaks, and setting vaccine schedules and vaccine policies. So I'll give you some examples in how integration of primary care and public health led to wider national coverage. So primary care providers were involved in active outreach to at-risk and marginalized communities in the influenza vaccine in the UK and the US, H1N1 vaccine in Europe, HPV virus in a lot of in low and middle income countries. And another way is a co-location approach, which is by integrating the administration of routine vaccinations with regular primary care clinical visits. So this increases the efficiency because they're doing two things at once, and it allows an increase in uptake of the vaccine. So some examples in the literature were HPV vaccines in Cameroon that were administered during cervical cancer screening appointments. And in Italy, where regular primary care visits and meningococcal B vaccines were administered at the same time. Next slide, please. Yes, so for the COVID-19 pandemic, immunization is a key factor to controlling it. However, the challenge remains to ensure equitable distribution of the vaccines between and within countries, just as David mentioned in the stats he provided earlier. A lot of the literature was focused about the potential role of primary care in the vaccine rollout, but there was a gap in understanding the actual implementation approaches. So the objective of our study was to describe the implementation approach in the vaccine program with a focus on planning, coordination, and service delivery, understand the level and type of primary care involvement in the vaccination campaign, and to understand primary care providers' perspectives on public health and primary care integration during that implementation phase. Next slide, please. Now I'll go over our research methods. So first, I'll explain our study design and setting. So it was a cross-sectional online survey that was disseminated to a convenient sample of primary healthcare professionals through member-based organizations and professional networks the survey was open for 4 months, from November 2021 to February 2022. And these were disseminated by email and online newsletters mainly. All our study materials, so that includes our survey, our informed consent form, the letter of invitation, all of these materials were translated to the official languages of the UN, so Arabic, Chinese, French, Russian, and Spanish, as well as Portuguese to accommodate regional and linguistic differences around the world. So the eligibility criteria to participate in the study is a minimum age of 18 and participants that self-define themselves as primary healthcare professionals. So that includes academics, researchers, government staff, policymakers, and primary care providers such as general practitioners, family doctors, mid-level healthcare providers, nurses, and community pharmacists. They had to be able to complete the survey in any of the available languages. And one of our exclusion criteria was any specialists or tertiary care professionals. So for our recruitment strategy, we targeted established primary healthcare professional networks and member-based organizations in different regions of the world. So we did a lot of active outreach to a lot of different primary care networks, such as WONCA, the CFPC, the George Institute, a lot of the different colleges, family medicine member-based organizations around the world. So these networks and organizations disseminated the letter of invitation either by email, text, or through their social media accounts. And in the letter of invitation, there were brief details on the study and a website link that would take the participants to our informed consent page. Once they reached our informed consent page, they would be able to learn more about all the details pertaining to the study. And then if they agreed, they were prompted to start the survey. Generally speaking, our aim was to recruit a minimum of 300 participants with a goal of having at least 5 participants from 30 different countries. And one of our inclusion criteria was to have a minimum of 5 participants for analysis at the country level. Next page, please. So how did we develop this survey? So we split our research team into 2 committees. There was the formative committee that created the survey questions based on the study objectives and existing literature. So we also took into account the WHO frameworks for monitoring and evaluating vaccination programs and evidence-based health systems indicators for integrating primary care and public health. So that was the first committee. Then the summative committee verified and approved the questions for validity using their expert knowledge. So we went through an iterative process until the final version was approved by both committees. So there was a lot of back and forth till both committees felt it was appropriate. And our aim was to ensure that the survey was brief. It would take less than 15 minutes to complete and approximately 27 questions. And that it was appropriate to an international and conceptually diverse audience, because sometimes different vocabulary is used to describe the same thing. So we just wanted to make sure that it was appropriate across different contexts. So our survey, now if we go about the data collection and participants' privacy, the survey was hosted on Qualtrics and it was open to anyone who had access to the link. There were no limitations. All survey responses were anonymous. We didn't collect any IP information or any identifiable personal information. And participants were able to withdraw at any time by just exiting the survey. We opted not to have forced responses in case participants preferred not to answer specific questions. They were reminded if they missed any questions, but were able to proceed regardless. So for our data analysis, our main objective was to provide a descriptive analysis of the outcomes and conduct comparative analysis by income level. We used Microsoft Excel and SPSS to clean the data and for the analysis. Yes, so descriptive analysis was conducted for quantitative data and thematic analysis for qualitative data. And of course, the study was ethically approved by the Health Sciences Research Ethics Board at the University of Toronto.
That's great. Thank you so much, Rivka. We thought we'd take a minute just for people to refill their coffees, stand up, and see if there are any burning questions before we move to the findings. Welcome, everyone. Welcome to Dr. Bisroor as well. We continue to be impressed by your engagement and support of our center. Any burning questions before we move on? So let's move on, and we'll make sure we leave time for discussion and feedback at the end. Sumit.
Thank you, David. So yeah, I'm gonna go through and present some of our descriptive analysis. Our analysis is ongoing, so this is more of an interim analysis. The work that Rivka just presented in terms of our protocol, like David had said, has recently been accepted for publication in the African Journal of Primary Healthcare, and should be published, well, they say within the next 30 to 90 days. So we'll certainly share with Manushi and Abhishek to share with the network when that becomes available. So going back to this study, I don't know if it was mentioned, we call it FMVax, Family Medicine Vaccine. I don't know if David, if you mentioned that or not, but that if you hear us talk about FMVax, we're talking about this study. It was our internal short form. So in terms of responses around the world, David, is there a way for you to press play somewhere? Yeah, thank you. So we had really good representation. We were able to include 32 countries in the analysis, and that was responses that had countries that had responses from more than 5 people. We had responses from more countries than that, but we'll include them in the qualitative work, and we'll include them in any of the findings where we're looking at the data as a whole. But in terms of our comparative analysis and our descriptive analysis, we did make that decision to exclude countries that had less than 5 responses. And that rationale was based, just to give you an idea of the process, from a research team point of view, that was based on the experience of our colleague Felicity Goodyear-Smith, the study that David had mentioned that we modeled, or this is kind of the part 2 of. They found that having 5 countries, somehow 5 responses per country, somehow there was a bit of saturation achieved in terms of the descriptions and in terms of the qualitative work. So that's where that came from. Next slide, David. So in terms of the characteristics of the participants, at the end, we had 32 countries and 100. Oh shucks, this graph is a little bit is missing one line. But we had, Rivka, how many participants did we have altogether?
394.
394, thank you. And 50% of them were family doctors. That's the line that's missing. We're primary care providers, but the majority of the primary care providers were MDs. And that's the line that's missing from the table. The other primary care providers, again, this was self-identified. We had a small percentage that were mid-level healthcare providers, registered nurse or nurse practitioners, and then there was a very small category for people that kind of were other. So majority of them were primary care medical doctors. The other self-identified professional groups, there was less than 10%, about 8% were government staff or policymakers, 30% were academics or researchers, and then we had a sort of a broad category for the rest of the 10 to 12%, NGO professionals, public health professionals, students from various disciplines. In terms of years of experience, the mean number of years of experience working in primary healthcare was 14, and we had a reasonable balance in terms of participants, in terms of gender distribution, close to 50-50, although there were the majority group was female at 53%, males at 46%, and gender diverse at 1%. And then in terms of the characteristics of those countries where we received responses from more than 5 people, it was an interesting spread, actually. It was like almost 1/3, 1/3, 1/3, lower and middle income country, upper middle income country, high income country. But we had 4 groups. So it was more like, I don't know, like 27%, 27, 27 or 28. And then about a small proportion, 9% from low income countries. Next slide, please. In terms of, I thought it would be like, rather than presenting the data with a lot of tables and results, I thought it might be interesting to, because this is a work in progress, I thought it might be interesting for us to talk you through our results and talking through a bit of the rationale of how we're doing our analysis as well. Because I think that's important as well to share in terms of methodology. And this is a relatively new world of large online surveys. Probably in the last 5 to 10 years, there's been an explosion, and certainly during the pandemic, an explosion of large international surveys. And there's a lot of challenges with them in terms of wondering about sort of the reliability of results and the validity of results. And I think we have to think about our analytic methods to match that. So, so it might be more descriptive because we don't have a good denominator. One of the biggest challenges of this type of work, of doing online studies where you're sort of sending out across professional networks, is that we don't have a denominator. So calculating rates or proportions, we can do them internally within our survey, but because we don't have a good denominator of our response rate, for example, we have to be very careful about the types of results or inferences that we make from our work. So the way that we approach the analysis, as David mentioned earlier, was we as the first step, and we recognize that there's such a richness of the data that there'll be sort of multiple phases of our analysis, and we look forward to that. I think there's very, very, very interesting, rich findings that perhaps we can present again at some point in the future. But for now, what we did was we looked at some of our outcomes across those the 4 income groups: low income countries, low and middle income countries, upper middle income countries, and high income countries. The implementation outcomes that we looked at, that we're reporting on, we looked at a bunch of them, but these are the ones that have some interesting findings: vaccine product, registration process, location of vaccine administration, so exactly where an individual was receiving the vaccine, and then what tools were used for tracking vaccination, and then cost. And as David mentioned, at the Besserer Center, and I think across primary healthcare research, equity is a really, really important concept. And I think some of these results, I don't know if that, well, again, maybe that's for our discussion. They demonstrate certainly that things are different in different parts of the world if we think about income, and that's a known thing. But in terms of a pandemic where we thought that there was going to be a lot of social capital invested into the health of the population around the world, I mean, maybe I'm naive and I was expecting something different, but it does show that the same types of inequities exist, and probably were also I don't know what the word I'm looking for, but they were also really highlighted during the pandemic. So in terms of vaccine product, upper middle income countries and high income countries pretty much exclusively had the global supply of Pfizer, and then some Moderna and some AstraZeneca. Low income countries and middle income countries. There was a difference. The Moderna product made it to the low middle income countries, but didn't make it into the low income countries with a high proportion. I mean, these are the top two. Certainly other vaccine products were available, but these were the top two. Johnson & Johnson for low income countries, the AstraZeneca product as well in the low income countries, Sinovac in the low and middle income countries, as well as Moderna. And I mentioned the other two. And then in terms of registration process, it was also very interesting. There's not a particular, this is more of a description. So in low income countries, it was no worries. The majority was walk-in, no registration or appointment needed. In low and middle income countries, it was a combination of 3 different things: online, walk-in, or having an appointment made at a health facility. And upper middle income countries walk-in, and then in high income countries, a bit of combination as well. In terms of the location of vaccine administration, the main finding really was that in the higher income countries, hospitals were not used for vaccination. Primarily across the board, vaccination around the world happened in public primary healthcare facilities. There are private, again, these are the top two. There are private, there's private in there. There's home, about 10% of vaccines administered around the world were administered at home, but these are just the top two. So really predominantly in a public primary care facility. In the lower income countries, hospitals were utilized, but not at all. Pretty much, it was a very low percentage. And the number 2 actually in upper middle income countries and high income countries was a non-health facility. I can give you my personal example. My second vaccine was in a hockey arena in a suburban location, and it was freezing, right? So I would never thought, I found that very interesting that I have nieces and nephews that play hockey, and I was going into those hockey arenas to get my vaccination. So I thought that was, it was fun for me. The other outcome we looked at was tools for tracking vaccination. It was primarily a combination of digital or paper-based certificates. The one highlight was that the high income countries did quickly develop electronic registries. There was a lot of funding for that. And some of it was more around public policy. I mean, this is an inference or a thought on my end. We didn't find it in the studying, but in the findings. But I wonder, because a lot of the higher income countries had vaccine mandates and other things. So it was really, they invested a lot of money, not because it's good for the population, but it was good from a public health point of view around having that very important piece of data around transmission and knowing whether somebody was vaccinated or not. And for cost, majority was free. Like really, I mean, there were all the different various models of paying for medical care or paying for medications or vaccines. All of the models existed, but in all, like overwhelmingly, all of around the world, most people, more than 90% of the people received this vaccine free, which is pretty cool. I think, anyway. You guys can let me know afterwards what you think, but I think that's really, really cool. Okay, next slide. And one of the questions that we asked around equity was the vaccination, how the perceived from the healthcare provider or primary care provider, it was really primary care professionals' point of view. What was their impression around how well their country or their region or their context did around identifying high risk and high priority groups. So, the high risk groups from a health point of view, but also priority groups around exposure, like nurses and paramedics and any kind of frontline worker. And the interesting thing is the majority felt all of the respondents felt overwhelmingly really good about that. There were some differences, but overwhelmingly it was there were sort of there is, you can look at this from an equity lens as well, or a policy lens, but overwhelmingly it was quite positive. I'm mindful of time, so I'm going to start speeding up a little. I find the results very interesting, so I apologize for taking some time away from you, David. But anyway, the other outcome, the other main outcome that we really looked at was around perceived outcomes. So the first one was around implementation. This was more around effectiveness and integration and other things. So the ones that we looked at were perceived effectiveness of the vaccination campaign in a professional's region, the level, the location or the type of involvement geographically of a primary care provider in the vaccination, in conducting or doing vaccination, whether the provider perceived that the primary care system contributed to the vaccine efforts. And then an interesting confounder perhaps that we looked at was around whether how involved primary care had been prior to the pandemic in routine vaccinations, non-COVID. And then the other two were community engagement and adequate data. And these aren't accidental outcomes that we're reporting. This is the framework for a good primary healthcare system, as Rivka went into a little bit during her discussion around what is public health and what is primary care. So the trends really, they're there, and really the perceived effectiveness, higher income countries, the professionals felt that it was more effective, but I think we have to unpack that a little bit, perhaps in the discussion. Primary care involvement, it was where primary care professionals delivered vaccines. Normally, overwhelmingly, it was in the usual setting. Sometimes it was in a setting close to their usual setting in their own community. So overwhelmingly, primary care providers, the people who were vaccinating, were from the area. Whether the provider perceived that the primary care system contributed to the vaccine effort, overwhelmingly positive. This next one was an interesting one, the confounder one, where do primary care providers provide routine non-COVID vaccines? And in high income countries, it's often or always, and in lower income countries and low and middle income countries, it's around 40 to 50%. People responded often or always. In upper middle income and high income countries, it was 60% and almost 80%. So that's probably a policy important confounder for us to consider in our analysis, and is an important policy point. Interestingly, community engagement and having adequate data to make good healthcare policy decisions across all countries. The community engagement was poor, slight to moderate, and data was moderate. There was not any very much overwhelmingly positive thoughts around that in terms of people's perceptions. David, next slide, please. Yeah. Perceived fact, this is more of the qualitative work that we've started to do. We're doing a thematic analysis, but sort of as a basic implementation, facilitators to implementation and challenges to implementation. The facilitators were the prioritization of vulnerable and high-risk groups. Cold chain requirements were met. Online registration was seen as a plus. The rapidity of scale-up, mobile clinics, teamwork. Challenges were things like political commitment, supply issues, hesitancy, misinformation, coordination, communication issues, access and transportation to vaccine sites for people living in remote areas. To me, these felt expected. And then the last slide that I have, or the second last slide that I have, is around perceived integration of public health and primary care. And this is interesting because it's, it'll be interesting to tie this to the outcomes, but it's interesting because it seems as from a perception point of view, some of the high income countries seem to do not that great, the lower shades of blue, and some of the middle income countries and the lower income countries seem to do quite well. And I think David's going to unpack that a little bit in the discussion, so I'm going to leave that. Okay, Next steps, what are we going to do? Just before I hand it over, we're going to continue this descriptive analysis. We're going to do our comparative analysis, deepen our qualitative work, and important for us to recognize and address our limitations. In addition to just the methodological limitations that I talked about, the context around the pandemic was changing fast. Around vaccinations, there were variants, boosters, availability of COVID treatments, which may have affected vaccination programs. It was very complex and chaotic, I feel, for me anyway, as a family doctor and a healthcare system or a health systems researcher. So we're going to maybe in the future, we're going to unpack that a bit.
Indeed.
Thanks, David.
Thank you very much, Sumit. It's been a real treat working on this with you and with Rivka. I'll quickly go through a few slides. I want to make sure we leave enough time for feedback and questions. As Sumit mentioned, some of the limitations also include that this is really data around perceptions. This was a known limitation from the start, but in fact, we feel that for primary care, which is not only a complicated but also complex box, perceptions are important. This was a convenience sample. There was variable penetration, but we did make a great effort to translate the survey to 6 languages, the 5 UN official languages, plus Portuguese, because of some known community-oriented strengths in the Lusophone world. And we received responses from all but one of those languages. This confirms known research, and we're happy to share our references. It fits well in a growing body of research, which is highlighting the importance of these findings. So the early lessons from the study are that primary care providers are important in these efforts. They're important to reduce vaccine hesitancy, to identify priority groups. They're important simply as vaccinators at times. They're important to help us think of integrated information systems and interdisciplinary collaboration. I wanted to make sure that I highlighted the importance of trust in primary care. Danielle Martin, who is the chair at the University of Toronto now, co-wrote a Besser paper around the importance of trust. We have been growing a body of knowledge looking at cross-contextual and between-country comparisons. We feel this is an important methodology. This study is yet another example of that. And indeed, trust is at the foundation of health systems. And as we increasingly go towards virtual models of care and towards perhaps technological advances, we must not forget the importance of trust. And this is where primary care providers can help, for example, reduce vaccine hesitancy amongst individual patients. The issue of agency is an important one next in the discussion. So we see variable levels of agency, how much control primary care providers have in their own immediate practices. In Canada, one of the lessons from the Besserer Center is that we have, by global standards, a very high level of agency and control over our individual practices, who we take, who we leave out of our practices, the limits of our practices, and how we coordinate and organize ourselves. And for public health, this becomes difficult to seek a coordinated response. And so I think this is an important issue as we look towards more coordinated health systems. I wanted to make sure that I showed you the slide. This is my daughter's interpretation of the importance of not only but transdisciplinary thinking. I think we are still stuck in multi or pluralistic approaches, but increasingly we have to move towards interdisciplinary and transdisciplinary approaches. And this is truly about working together for the betterment of population health and giving back some agency to patients. So some of the methodological lessons, health decisions are variously devolved to regions around the world. And it's interesting that we were only able, for convenience reasons and for capacity reasons, to look at regions in but a couple of countries, including China and India. But in very devolved health systems, Canada included, it's really important to look at the regional level where health decisions are made. And so one of the methodological lessons that we're thinking about is how to do that properly, And we might have to map that properly to know the proper level to engage, research, and advocate at for global health. I think there's a methodological paper in the writing there, and Neil Aria's project, our colleague Neil Aria, is looking at exactly that, mapping family medicine and primary care around the world. And the website for that is globalfamilymedicine.org. It's one of our other projects that ties into this one. So I just wanted to finish with a very interesting paper from Nature that I came across last week. And it's about this level of engagement, at which level, in which region. These economists and psychologists looked at whether exposure to COVID-19 increased altruism. The good news is, yes, it did, but variably so around the world. They found that in Italy, where health decisions are made at the national level, people were more likely to give and become altruistic at the national level and beyond. Whereas in the States, where health decisions are made at the state level, people were more likely to engage at that level and think perhaps less in global or cosmopolitan ways. And I think this has great implications for us as society, as a species. We know that the Black Death from the Middle Ages has greatly affected our genetic makeup. This is another paper that we came across in the Globe and Mail, our national newspaper, just last week. And we think that we are about to face an evolutionary shift. And in fact, we need to think more globally for the betterment of global health. And we think that thinking only parochially and regionally, without thinking of the global population and the needs to vaccinate everyone for this pandemic to be behind us, is increasingly more important. So we thank you very much for your attention. We went through the discussion quickly to leave some time, and I'm going to stop sharing some screens here so that we see all of each other in person. Thank you very much for the opportunity. Manushi, over to you.
Sorry, I was speaking on mute. I do see. Oh, there's a question for the team in the Q&A box, and it is from Dr. Vaini. And she has 2 years of experience in general medicine in the city of Bukavu in DRC. So she says, with my colleagues, we are trying to set up a system of volunteers for family medicine to ensure universal health coverage. This forum has edified me by seeing how family medicine, by its proximity, has helped to vaccinate the population. Right. We are asking for help by training. Right. So perhaps, Dr. Vaini, you'd want to reach out to Dr. Ponka and team separately. We'll share our emails. But David, if you want to say something about this.
This is exactly what we hope for, right? We hope for increasing connection. Yeah. We talk about trust between patients, but really we're building a network upon networks here of practitioners passionate about equity, passionate about reciprocity. That's what this is all about. Thank you very much for your comments, Dr. Vaini. And I'm trying to Sumit's typing our contact information, and we would love to have a call with you to explore areas of intersect. As I mentioned at the outset, we are about to launch our next CORIG studies. That's the stand for COVID Innovation Grants. We had one, we continue to have one in Indonesia, South Africa, and we'd like to launch in Sub-Saharan Africa. And it's a great pleasure to meet you. Thank you.
And I just wanted to extend my greetings to you, Dr. Vaini. I worked in Bukavu in the late 90s, early 2000s with Médecins Sans Frontières, and I lived and worked in Bukavu. So it was one of my first experiences as a young physician working in global health. And I will always have very fond memories of living there and working there. And yeah, I just wanted to share that. And I will put David's contact information here, and that's what I was about to do. Or Rivka can do it because she's better at that.
That's great.
Brilliant. Are there any other questions or queries or thoughts of the study? Do you agree with the results? Do you disagree? Are there any insights you want to share from your surroundings? I think for me, Sumit, that was very interesting that you for your vaccination, you had to go to a hockey arena.
Yeah, and I think and some people went to like a concert venue, or some people went to the convention center. It was very interesting. Yeah, what they did.
For me, it was in a local temple. So the temple premises agreed to be part of the vaccination drive. And so it was funny, because we had to take off our shoes, sanitize our hands, enter the premises. First, you go pay your respects to the god, and then you get vaccinated. And on your way out, the priest was handing sweets that you did a good job by getting vaccinated.
That's transdisciplinary for sure.
Yeah,
and very community focused.
Yeah. And because if the temple is endorsing a vaccination program, then everybody is bound to go get vaccinated.
Yeah, I mean, we all felt, especially as parents, but all of us felt this vacillation between not only our sector, but between sectors, right? The different priorities between education, infectious disease, chronic disease, economy. We're seeing the impacts on economy now. So how do we reconcile all this? How do we think that every law project should be a law for human health and wellness and betterment? We're far from that, unfortunately, but at least we are talking about it. This pandemic is highlighting the need for integrative thinking and looking at the big picture and generalist thinking. And I think it's an opportunity for discipline to shine once we get out of the current capacity crisis.
I agree. And it's also created this health awareness in the population in the pandemic that we can build on it, not let this go to waste, and sort of leverage this opportunity that there are so many innovative ways of providing healthcare to people, increasing this access. I think that's very interesting.
Yeah, absolutely. Yeah, from my personal experience as a family doctor working in Toronto, the whole idea around virtual care, for example, has changed my professional life forever in terms of how I there was a paradigm shift there in terms of access around patients not having to come into the office to get primary or family medicine care from me. So that's my personal kind of clinical experience. And it will never go. It will always be now it was a new part of how I provided care, and I don't think it's ever going to go away, right? So it was a real, for me, professionally, it felt like a paradigm shift.
I see that Renu is in the attendee list, and sorry to put you on spot, but I know that during the pandemic, Renu was actually doing field work in one of the rural constituencies in India. So Renu, you want to share some of your learnings from the field? And it's perfectly okay not to respond as well. I didn't mean to put you on spot. Sorry. Abhishek, can we give talking rights to Renu? Is that a thing?
I've actually given her talking rights, and she needs to talk.
Okay, all right. So I remember she was sharing how the community health workers in India had come together to deliver the vaccine, to push the COVID appropriate behaviors, and she had some interesting insights. Renu, if you want to take over.
Yeah, hi Manush. This is Renu. Yeah, I work with Manush and Praveen, and I'm from the George Institute for Global Health. And yes, I happened as a part of a study. I happened to hold in-depth interviews with the community workers, doctors, and other multi-purpose workers at the primary level, and they had very vivid experiences that they shared of their, their participation for delivering the COVID vaccination to the public at large. They So first of all, it was an additional work burden to them because they were driven by targets, and they had to, at any cost, achieve those targets, daily targets, weekly targets. So it was a lot of work burden, and they did everything that they could possibly to motivate the population. And then they had to go to resort to other methods by counseling or requesting. There was a lot of stigma around COVID vaccination, and then the village authority called the Sarpanch, the Panchayat, the village secretariat authorities would intervene, and then they would, they would go a bit harsh. They would say you wouldn't get your ration, or you could electricity could be stopped. They had to, not that it was supposed to be done in any way, but they had to resort to mechanisms like that to to kind of scare them. So when nothing worked, they had to do it that way, and then it paid off in the long run, because people realized how important to get vaccinated. When they went through the COVID first wave, second wave, then they realized what people are trying to do are actually beneficial, and their trust in the community workers increased manyfold. And now they hold a very prestigious position in the village population, and they say that has really increased their social status. So it was a lot of challenge, but at the end, it worked out both for the villagers, for the population, and for the community as well. Yeah.
Thanks, Renu. Yes. So yeah, I do remember reading about this, that families that refuse to get vaccinated, their water supply or the electricity would be cut off.
Yeah.
And those were some of the extreme measures that were taken, but well, it did pay off. Nice. Right. I see we are 2 minutes beyond time. So if there are no questions, we'll close this webinar. Right. Thank you, everybody, for joining us, especially David, Sumit, and Rivka, and Abhishek, of course. Special thanks to Abhishek. And we have more webinars planned under this series. So watch out, follow us in our Twitter space. That's where we do all our major announcements, and we'll be back very soon. Thank you, everybody.
Thank you very much. Good evening.
Thank you. Bye. Good evening.
Bye.